Mobeen Sayed from Drbeen.com. Tell me this, can you hear my voice? I'm not able to see my audio levels. So let me know if you can hear my voice and we'll start. Good morning, everyone. I hope you can hear my voice. Today, we are going to start discussing about the tragic situation with one of my class fellows' son. His name is Salman Tahir. He was a fourth-year medical student. I had talked about him before as well, that I wanted to share his situation. He was a rare case of COVID-19 meningitis. Most of the time, COVID-19, as we know, can hit mostly the respiratory area and then cause respiratory symptoms. Sometimes it can cause headache, sometimes it can cause GIT symptoms, other times it can cause other symptoms as well. However, this specific case is where the patient had meningitis that is developed, and within 4 days, patient passed away. So I wanted to share that with you. So I'm going to share my screen. And this write-up that you would see is actually written by his father. So Dr. Salman Tahir Salim, he was a fourth-year medical student, 21 years, 5 months, and 8 days. Very young man, tragic situation. Fourth-year medical student. His father, Dr. Tahir Salim, he's a pediatrician. He was my class fellow. Was my class fellow when we were studying together. His mother, Dr. Shabnam Tahir Salim, she's a gynecologist. The reason for, and all of this information that is here is, excuse me, is given by his father, and he has approved that he has allowed me to share this information. The reason I brought up both parents being doctors is that sometimes we become careless and we feel that we may not, some people are not very careful. Here, there is a situation where a family of doctors is involved. And of course, if I would expect someone to be careful and be fully aware of the risks, that would be the doctors. So even then, it is possible that the tragedy can visit. So this is important for all of us to understand that don't take it lightly. Don't take coronavirus lightly. Don't take COVID-19 lightly. Make sure that you are fully prepared. You are taking care. You are protecting yourself and others around you. So with this is a young man. Here is what happened. Here is the history. And his father has provided me with all the labs, x-rays, CT scans, and history. Today, I'm going to go over the history and show us the labs, the chest x-rays. If you would like, we will go over the labs tomorrow, if you would like to discuss the labs as well. So let's start with the history here. What happened was on May 24th, the patient, the young man, he developed headache on waking up in the morning. So he woke up in the morning and he complained of headache. Then he developed fever in the afternoon, 99 to 100 degree. He kept having the headache in the frontal region for the whole day, and the fever was there as well. So I believe when I spoke with his father, I believe that they said that they asked him to go to sleep and rest. In the meantime, they did symptomatic treatment, and because he only had a headache, they were not suspecting COVID at that time. So the patient started taking paracetamols, Dexibuprofen 400 milligram, and he also was isolated in a room as well, as the suspicion evolved that maybe there may be COVID. So he was separated. On 25th, the next day, his fever developed to a high-grade fever, 102 to 103. He developed continuous headache and now in the frontal and occipital part both, that is in the front and in the back of the head as well. And he started developing neck pain as well. There were no signs of meningitis though. So he continued on Panadol. His oral intake was fair. He didn't have any history of cough, flu, sore throat, body aches. I should put a Y over here. Body aches, nausea, diarrhea, or any other respiratory symptoms during this 48 hours. So the first 2 days, there were no symptoms other than headache. And then as you saw, neck pain. On 26th, he had headache, he had fever, neck pain continued, and he started developing neck rigidity as well. So the rigidity of the neck is a sign of meningitis. He did not have kerning sign. So kerning is a test for checking for the meningitis. So the kerning was negative. Oral intake reduced. He continued on Panadol. They visited a physician, and I think the doctor asked him to start taking muscle relaxant as well, thinking that there may be muscular pains. At the same time, his labs were sent. So the labs were CBC, CRP, D-dimers, and LFTs. There is a comment from Jim that did you test for the vitamin K levels? I believe not, but we can look into the labs tomorrow. And thank you very much, Margaret. This is a very sad situation, and I am in awe and grateful to the parents that not only his mother, I have put the link out in the description, not only she, after his death, soon after his death, his mother actually went out on a TV interview and wanted to caution everyone not to delay the treatment for COVID-19, not to think it is not COVID-19, and to save others and save other children. What a brave and what a hero they are, that his father wrote down this history after I think 4 or 5 days of the child's passing away, and he wanted us to share this so that others are also aware that this can also happen. So I'm grateful to them and lots of condolences as well. So 26/5, headache, fever, neck pain continued, neck rigidity developed, kerning sign was negative, oral intake reduced, patient was taking Panadol, muscle relaxants were given, then complete blood count, CRP, D-dimers, LFTs were sent. On 27th, Glasgow Coma scale was 15/15. Glasgow Coma scale is a scale in which you see the alertness of a person to assess that what is the prognosis. So 15/15 is fully aware. So we are all here, we are 15/15. And as the patient starts developing issues that may cause, let's say, brain inflammation or brain damage, then the Glasgow Coma scale would start going downwards. Normally, comas, I believe, below 8 and 6, below 8 is actually very dangerous. And here the patient on 27, so keep an eye on the number of days. He started on 24, 25th he developed his symptoms further. 27th is when he is now a little more in trouble, so much so that now they're looking at his Glasgow Coma scale. His heart rate went to 112. His respiratory rate went to 40. So this is a very common issue with COVID-19, that as the breathing starts becoming impacted, patients' breathing rate or respiratory rate goes up. At the same time, heart rate goes up because of fever. It can also go up because of anxiety, because of stress, plus because of the volume depletion. Blood pressure is 170, which is sort of normal. It's okay. And temperature is 101. Hospital, he was admitted to hospital. In the hospital, lumbar puncture was done at 3:30 in the morning of 27/5. And he was put on Ceftriaxone or Rosfin, 2 gram BD. So he was started on antibiotics, antibacterials. So we'll come to oxygen saturation in a second. So there's a question, what was the oxygen saturation? So I believe till now his oxygen saturation was okay. And look at this, the next section of the day. So this is 27/5 yet. So May 27th, 11 a.m., he started having increased tachypnea. So his breathing rate increased even more. And then he was started on vancomycin. Vancomycin is another antibacterial as well. So physician saw him in the hospital, neurologist saw him, neurologist asked for a CT scan. So now he is on Panadol and other symptomatic treatments, but at this time now he's on Ceftriaxone and he's on vancomycin. At 12 p.m. same day, his oxygen saturation was 91 to 92%. They started oxygen. So nasal prongs were used, 2 to 3 liter per minute oxygen was given. Chest X-ray bilateral infiltrates, and I'll show you the chest X-ray in a second. So he had the infiltrates on both sides. PCR for COVID-19 was sent. So again, please keep an eye. This is a very rapid progression. Started on 24th, became much more ill on 25 and 26, and now we are talking about 27. And the day of 27, so just 3 days after. At 12 p.m. on 27th, same day, oxygen saturation was 91 to 92. He was started on the nasal oxygen, chest X-ray and PCR. COVID-19 was done. Chest X-ray was positive. Then 12 p.m. to 8 p.m. on the same day, tachycardia was 130, 140, 150 per minute. And this is a very common thing, not 130, 140, 150, but tachycardia with fever, it happens. And then with COVID as well, I've seen the tachycardia occurs as well. In addition to this, if patients start taking hydroxy and azithromycin, that can also cause tachycardias or bradycardias because they can cause QT interval changes. So this patient had tachycardia. With that tachypnea, increased breathing rate, 40 to 50 per minute. Dyspnea increased. So his difficulty in oxygenation, so his difficulty in breathing increased. Oxygen requirement gradually increased. They were met with an infectious disease consultant who looked at the patient, and he started the patient on Acyclovir and Dexamethasone. Acyclovir is an antiviral. Most of the time it is for stopping the DNA replication in the virus, for the DNA viruses. Plus, he was started on dexamethasone. And we all know that dexamethasone is actually a good drug when a patient is in a serious situation. And we had that study, we discussed it a few days ago as well. So he was started on dexamethasone. So there is a question that MBOL is saying, still nothing for any virus yet. So other than acyclovir at this time, or dexamethasone for the inflammation, nothing for specific for COVID-19 yet. His blood pressure started dropping. So if you see here, 85, 90 by 60 or 70. So both systolic and diastolic started dropping. He developed cold, clammy extremities. Right eye started swelling. So this was their observation that not only headache was there, the patient had swollen eyes as well. So right eye started becoming swollen and red and slightly proptosed. Proptose means slightly bulging outwards or slightly moved out. So patient was on acyclovir and dexamethasone. Infectious disease consultant added acyclovir and dexamethasone. Labs were repeated. PCR meningitis panel was sent. So then he developed a rash all over his trunk and his urine output started reducing. So I haven't discussed this at what was the reason for the rash. Was this because of a drug reaction or was this some other reason? But he did develop a rash all over his trunk and his urine output started reducing. So urine output is reducing. This is a very common outcome as well. As we have discussed in the past, that the ICU doctors who are managing COVID or who are managing shocks, one of the issues that they have to handle is that on one end, they need oxygenation and they need blood pressure to be maintained. On the other end, blood pressure is dropping and they need to keep the blood pressure up by giving IV and keep the renal system up. But at the same time, if they give too much of intravenous fluids, that can cause further congestion in the lungs. So there is a very delicate balance that they have to work with. So same day, 27th, 12 p.m. to 8 p.m., this is what happened. And now if we continue on, 27th, 8 p.m. to 28th morning, so evening of the 27th till the morning of the 28th, the tachypnea worsened, so his breathing rate increased, tachycardia worsened, heart rate became increased, dyspnea or the breathing in difficulty increased, blood pressure dropped to 90/60, oxygen saturation stayed at 93-95. So from a WHO's point of view, or from a clinical point of view, 93% was okay, not bad. But keep in mind that it was not the respiratory issue, just the respiratory issue. He had developed COVID-19 meningitis as well. So oxygen requirement increased to 10 to 15 liters per minute. On 28th, 8 a.m. in the morning, the Glasgow Coma scale started decreasing. So that means patient started losing consciousness. He started becoming drowsy and disoriented. So the Glasgow Coma scale is what we use to kind of see that what is the level of consciousness, and the level of consciousness started dropping. So he started becoming drowsy, but he called his mother intermittently. He was started oxygenation on BiPAP. So BiPAP is a mechanism in which it's not an invasive ventilation. Instead, it is still a mask, but it is with the positive airway pressure. So he started oxygenation with pressure now. At 10 a.m., anticoagulants were started. Rocephin or the Ceftriaxone was stopped, and Meropenem was started. So these were the drugs that were started. COVID-19 test came back, and that was positive. On 28th at 12 p.m., his Glasgow Coma scale dropped to 4 out of 15, so very low. Normally below 8.6 is very dangerous. He was intubated and on the SIM mode, that is mandatory ventilation. SIM mode is that even if the patient is not trying to breathe, the machine is going to make sure that there is a set number of breaths per minute that it is going to give. So that is called the SIM mode. And the chest X-ray was repeated, and the chest X-ray kept becoming worse. On 28th, he was started on Tocilizumab, which is one of the drugs to use in ICU for COVID-19. But he continued to deteriorate, and on 5th, or the May 29th, at 12:10 p.m., he passed away. So this was the history of the patient. Let me show you his X-rays as well. So on the day 1st, this was his X-ray. So if you see here, I think you can make out these are the infiltrates that you can see. There are some tiny infiltrates here as well. I believe these are the curly B lines that we look for. So he had the infiltrates, but if you see, a lot of his lung was still okay. Then next X-ray was this. So if you see in this X-ray, there is much more infiltrations. There is much more damage to the lungs. And as you can see, the basal areas are much more damaged. Plus, the infiltration is now going in the upper areas as well. Then here is one more X-ray. So apologies for the artifacts, but once again, if you see, The lungs are now much more filled with the infiltrations. However, it is not these infiltrations. If the patient didn't have meningitis, then I believe that this infiltration is still something that could have been managed. But this combination of meningitis with the infiltrations or with the respiratory issue is something that I think was really dangerous. It was fatal. It was tough for the child's body. And if you would like, please leave a comment that we can talk about. We can go over the labs. I have, I think, about 27 or 28 pages of labs if you would like to see them. But what is important here is that this was a case of meningitis. He started with meningitis. There was a little delay in understanding that this was a COVID-based meningitis, which we normally do not suspect. And unfortunately, in COVID, there is a symptom as well of just simple plain headache with eyes burning or eye ache or eye pain in the eye. It is a very common symptom. I have seen many patients. One of my friends, she's a nurse, she said that her husband a few months ago, he travels for his business, and the only symptom that person developed was severe headache for a day or two. And then afterwards, when he came back, he stayed with the children. They never suspected this was COVID. They just thought these were severe headaches he had. And then he was positive, and he never developed any other symptoms. Similarly, I have a few other patients whose primary presentation was headache. So now here is the danger. In this case, we are seeing a patient who has meningitis with COVID-19. And then it is not just the headaches by COVID-19 in general. So that is the problem. So my request to everyone who is in healthcare is to, when you have a presentation of headache, please make sure that, number one, make sure that you look for COVID-19. And number two, if you suspect COVID-19, start treatment immediately. In this case, if you can see, we are looking at Tocilizumab quite late in the panel of drugs or treatment or management. Plus, most of the management was towards bacterial meningitis in the beginning. And that was because there was no suspicion that this could have been COVID-19 that is causing the headaches. So this is the discussion for today. The takeaway is that please make sure that whenever somebody is complaining of headache, you are very alert that this could be a meningitis as well. So I'm going to answer some of the questions, and then I would hang up. If you would like to see the labs, please tell me, then we can go over the labs tomorrow. So let me see some questions here. Embol, in any case, err on the side of safety. Absolutely, absolutely. And it does not hurt to err on the side of safety. Even today, I was talking with a patient who said that her only symptom at this time, and she was not very much concerned about it. She said, hey, I'm having some shortness of breath, about 5 minutes, it's nothing. And she just talked about it in passing. And I said, you have to be very careful at this time. So because there is an epidemic going on, a pandemic going on, these symptoms we have to start assuming it is COVID until we rule out it is not. So, Mary, yes, thank you very much. And he was a mother-father doctor. He was becoming a doctor. His father says that he was such a loving son, and he was such a loving brother to his other brothers. So how did they diagnose meningitis? So once he was clinically. So I think I'll go over the labs tomorrow to see that what did the labs show. But in the beginning, because he started having neck pain and then he ended up in the hospital, it was clinical, and then I believe from the labs. So Patrick says, my wife had headache, then 10 days and had shingles. Yeah. Please do go over the labs. Okay, we can go over the labs tomorrow. We'll do that. So how did they diagnose? I discussed that. Meningococcal meningitis. So I think this was the viral meningitis with the COVID-19. Low vitamin D, do not know. I don't think that vitamin D levels were done. There's a question from Chantal. Did he have symptoms in the days leading up to getting the headaches at all? No. So that is the history which I heard from his father, my class fellow, was that he was fine. He was isolated. The family generally was isolated or caring. They were in the lockdown. And maybe he visited out for maybe some visit a day or two ago, but he didn't have any other either contacts or the symptoms. No light sensitivity. I haven't asked that question. Did he have headaches all along? So yes, his primary complaint was headache. He was comfortable. It was the Eid day as well. So Eid is a celebration. So it was I think the morning of Eid or a day before, when he slept and woke up, he had headache. And it is just the headache and fever, which then was added by the dyspnea and breathing issues. Why did oxygen saturation increase? It did not increase, it reduced. So 91, 92, 93, 95, that is a general behavior as the virus. What I have seen is that this virus causes intermittent symptoms. The fevers come and go, the pains, the fatigues, they come and go, headaches come and go. The shortness of breath is not continuous. It is 5 minutes, sometimes 10 minutes, sometimes a little longer. These symptoms come and go. So I'm sure that as the virus is attacking the respiratory system and it is happening in waves, the respiratory system may have been becoming improved. Similarly, our immune system is responding as well. So there's a fight going on, and it is possible that these improvements and then degradations are possible. Riza, thank you very much. Thank you very much. Very brave parents, and it's a tragic situation. Siddhartha, I can't speculate. So MRI, CT scan of the brain, yes. So yes, so we do have the CT scans on as well with the lab. So I'll discuss those tomorrow. Patient who's drowsy, we don't put them on BiPAP. So I think the problem is that he needed. This is probably before the drowsy that he was on BiPAP. Plus, he needed the oxygenation. Eventually, he ended up on a ventilator. So Acyclovir is mostly used for DNA viruses. It stops the DNA replication. So again, this is because the COVID-19 was not suspected. So because it was not suspected and because there was meningitis suspected, they started the antiviral plus antibacterial for most common disease pathogens. Yes, systolic was very low, correct. Oxygen saturation, as I responded, reduced. So I wonder if Decadron would have saved this patient. So he was given Dexamethasone, and then he was started on Tocilizumab as well. So he was given good drugs. It's just that it just happened so fast. Within 4 days, he went from headache to death. And the only thing that happened was meningitis and then pulmonary issues. So Guy, you are asking a question, is this common in patients in the ICU? So I don't think meningitis is common. That is why it is a rare thing. And I have requested his father to send it to the various publications as well so that more and more people are aware of it. But in the ICU, the presentation and the progression is different. That is usually more respiratory, which then becomes ARDS, which then becomes septic shock, then multi-organ failure and death. But this was a rare combination of meningitis with the respiratory system issues. So guys, thank you very much for joining me today. Thank you for listening in. My apologies, I'm keeping a little, it's difficult to present this case. We'll go over the labs tomorrow. Thank you very much. Please stay safe. All the cases I see, all the patients I see, and all of these tragedies that I see, the only thing that comes to my mind is to keep reminding everyone, please take care of yourself. Please stay safe. Keeping yourself at bay from the virus, madly taking care of yourself is not bad at this time. I have heard from many of my patients or my relatives or my friends that, hey, people laugh at me if I'm wearing a mask or they laugh at me that you are trying to be super careful and the virus may not be a big deal, I would always ask you to err on this side of caution. Always, please. Once a few months later, we have vaccines. Once this virus starts going away, we can do as much fun as we want. At this time, please take care of yourself. So thank you very much. I will leave now and we'll talk again tomorrow.